Now, as you know, these webinars are accredited with CME activities by the Saudi Commission of Health Specialties. Special thanks to the sponsor, Takeda, which is supporting today's activity. I am John Apostolides. I'm a consultant hematologist at King Fahd Specialist Hospital in Dammam. I will be moderating this webinar, and this week's topic is titled How I Treat Relapsed Refractory Hodgkin's Lymphoma, and it will be presented by Dr. Theodoros Vassilakopoulos. Dr. Vassilakopoulos is an associate professor at the Department of Hematology and Bone Marrow Transplant Unit at the Lyikon General Hospital in Athens, Greece. His research is mainly focused on malignant lymphoma, in particular Hodgkin's lymphoma, diffuse large B-cell lymphoma, and primary mediastinal B-cell lymphoma. He is vice president of the Hellenic, that is the Greek Society of Hematology, and chairman of its lymphoma section. He has participated as a PI in many international clinical trials. He is a member of the editorial board of international journals such as Leukemia and Lymphoma, Blood Cancer Journals and Cancers. He has been a reviewer in more than 80 journals, and he has authored over 170 PubMed cited publications with over 5,000 citations. I encourage all participants to submit questions through this platform, and we anticipate a productive discussion at the end of this lecture. So Dr. Vassilakopoulos, it's a great pleasure to have you with us. Thank you for accepting our invitation. The podium, as we would say in the pro-COVID era, is yours now. Thank you.
Thank you, John. I would like to thank the Saudi Society for Blood and Marrow Transplantation and Dr. Alaskar, the president, and my dear friend John Apostolides for this honorable invitation. I will try to be on time. It's not so easy, but I will try. These are my disclosures. Patients with relapsed refractory classical Hodgkin lymphoma fall into two broad categories: those with relapsed disease, who may relapse after complete remission or partial remission, those with primary refractory disease. These may be patients with stable disease, or more frequently, patients with primary progressive disease, either during first-line therapy, which is the worst scenario, or within 3 months from the end of first-line therapy. Progressive disease is defined as more than 50% increase on tumor burden from nadir and or the appearance of new lesions. The gold standard for the treatment of relapsed refractory Hodgkin lymphoma usually is high-dose salvage chemotherapy, followed by high-dose therapy and autologous stem cell transplantation. This is applied in patients up to 65 years old in our department, or even 70, without prohibitive comorbidities, in good shape, and more importantly, those who are chemosensitive to salvage therapy. For patients who do not fulfill these precautions, age and chemosensitivity criteria, we perform we give conventional salvage chemotherapy, but not followed by autologous transplant. And we have to keep in mind an important point, that patients with localized relapses in previously non-irradiated areas may be cured with salvage radiotherapy. And there are data from the German Hodgkin study group showing the success rate of more than 20% of this strategy, but especially in patients who are asymptomatic, have localized relapse without PET. If we have PET, it may be even better. In non-irradiated areas, and more than 1 year after the end of primary treatment, the probability to salvage permanently these patients exceeds 50%. So we have radiotherapy in mind for a selected subgroup of patients. However, the usual situation is more disseminated disease, either primary refractory or relapsed. And in this situation, we can give various salvage regimens, either platinum-based or gemcitabine-based, with the aim to achieve a complete response, preferably PET negative complete response. This is not necessary, but is highly desirable, and to successfully mobilize hematopoietic stem cells while concomitantly minimizing the morbidity. All these salvage regimens mainly depend on the experience of each center, and neither of these regimens has been compared with the others. Overall, 70% of the patients, I would say, are forwarded to transplant, being chemosensitive and successfully mobilized with these regimens. You see here the BEDGEV regimen that I'm using, gemcitabine and vinorelbine, which may produce even higher CR rates, but these CR rates should be viewed with caution because here the response assessment has been done with PET, and previously this was usually done by conventional staging with complete tomography, and metabolic assessment may be more flexible than the imaging only assessment because residual masses are very common in this population. In our department, we are typically giving IGEV, ifosfamide, gemcitabine and vinorelbine, and steroids, and we prefer this regimen over the platinum ones because it is a very good mobilization regimen, maintaining a very good response rate as well. And also, it's a regimen that can be used on an outpatient basis. A crucial question is, if we don't succeed to gain a metabolic CR with the second line therapy, with the first salvage, do we need a third line therapy prior to proceeding to autologous transplant? In this study by the Memorial Sloan Kettering by Craig Moskowitz, patients received ICE, and those who became PET negative were forwarded to high dose therapy and autologous transplant, and those who were PET positive received third line therapy with gemcitabine, vinorelbine, and doxorubicin, liposomal doxorubicin. And as you can see in the right of the slide, patients who achieved the PET negativity with ICE had the same good prognosis with patients who achieved PET negativity with GVD, while those who remained PET positive after the two regimens had clearly inferior outcomes, but still 30% could be cured by autologous transplant. So PET positivity after salvage therapy, after one or two regimens of salvage therapy, is not a contraindication for autologous transplant. On the contrary, conventionally progressive disease, conventionally defined progressive disease may be a contraindication. I will show the algorithm that we are now following in our department. We start with IGEV and perform PET just prior to the intended transplant, 2 or 3 cycles. Patients who are PET negative, defined as Deauville score 1 to 3, are forwarded to autologous transplant. Patients who have progressive disease receive, by conventional methods, receive third line therapy, and patients who are PET positive, Deauville 5, also receive third line therapy, while patients with Deauville 4 usually are forwarded to transplant directly, or if SUV is high, fall again the category of third line therapy. We use BRESAP, brentuximab vedotin, and ESAP as third line therapy, but PV monotherapy or PV-based combinations may also be used, and I am aware for the BV-Benda data presented by Panagiotis Kalogiannidis in the recent Congress of the Hellenic Society of Hematology. This is also a very popular regimen. And in the absence of BV, ESAP or DVD may be used. And then, after third line salvage, we do not perform any other attempt to achieve PET negativity. If patients have no progressive disease conventionally, irrespective of PET, we forward them to autologous transplant. But if they have conventionally defined progressive disease, if they progress under third line therapy, we discourage autologous transplant. This is our strategy for the time being. Once the patient has reached autologous transplant, the outcome appears to be something like 50% cure, and this is clear in several international trials, international studies, as well as in our data. So 50% of those who will be transplanted will experience further relapse. And it is very clear that we need some way to improve these results. There are three ways to improve the results. First is to increase the proportion of patients who actually undergo autologous transplant through the increase in the metabolic response rate of second-line salvage therapy. And this can be achieved probably, there's no randomized evidence, but there are phase 2 trials indicating that this is achievable outside the approved indication, the incorporation of brentuximab vedotin into second-line conventional regimens, or by a chemo-free approach incorporating brentuximab vedotin and nivolumab. Another way to improve the outcomes of the autologous transplant intending approaches is to increase the proportion of patients who actually undergo autologous transplant by brentuximab vedotin or BV chemo as a bridge. If the response to second-line salvage is inadequate, this can be achieved by brentuximab vedotin monotherapy or with BRESAP or BV-Benda or other BV-based combinations. And finally, there is the way to improve the situation by reducing the relapse and progression rate after autologous transplant with some kind of consolidation. The only approved consolidation in this setting is brentuximab vedotin monotherapy, but there are also some data with pembrolizumab which are very encouraging. But this is not approved at the time being. You all know brentuximab vedotin and its unique mode of action. And here, in a review published in the last year, I have summarized the response rates, complete metabolic response, and rates of autologous transplant with the incorporation of BV in platinum-based regimens or with bendamustine or the chemo-free approach with BV-Nivo. And you can see that the response rates are more than 80%. Complete metabolic response rates usually exceed 70%, and ASCT, autologous transplant, is performed in the vast majority of these patients with very good progression-free survival rates. So, in the absence of randomized trials, the incorporation of PV into the second-line regimens appears to be very promising, but is not within its indication for the time being. If the response is not good to second-line therapy, then brentuximab vedotin as monotherapy can be used as a bridge to autologous transplant, and there are several national experiences, retrospective experiences, showing more or less 50% response rate with 30% CR, and finally, a variable proportion of patients proceeding to autologous transplant using a BV as a bridge. And this is the usual strategy. As I already mentioned, we now use BRESAP and not BV monotherapy for this bridging to autologous transplant in patients who appear to be chemorefractory. Once the patients are transplanted, we have the opportunity, the approved opportunity, to consolidate the favorable outcome with brentuximab vedotin. And this is based on the results of the AETHERA trial. In the AETHERA trial, patients were forwarded to autologous transplant based on the absence of progressive disease. Even patients with stable disease to salvage therapy were transplanted and then randomized to PV or placebo. And this trial actually included patients deemed at high risk of further progression. These are primary refractory patients, those with early relapses less than 20 months from frontline therapy, and those with more delayed relapses but with extranodal involvement. In my view, more than 80%, probably 90% of all patients who undergo autologous transplant fulfill this criteria. And the results were very impressive in terms of disease control. Progression-free survival was 12 percentage points better with PV per the independent review committee, and 20 points from 45% to 65% per investigator. And at 5 years, this was maintained with 18% difference between the two arms. But interestingly, there was absolutely no difference in terms of overall survival. As patients had unfavorable profiles, multiple risk factors, the benefit in disease control from brentuximab vedotin consolidation was greater, but even those patients with multiple risk factors had no survival benefit. And in my view, this is due to the availability and the response to brentuximab vedotin, not as consolidation, but as salvage therapy following autologous transplant, and also the availability of other drugs. All the subgroups appear to benefit, but we should be rather cautious regarding patients who are PET negative prior to autologous transplant, who may not be adequately gain an adequate benefit by BV consolidation. And at the end, in the absence of an overall survival benefit, it was shown that subsequent therapy was reduced by 12 percentage points from 64% to 54, 10 points, 64 to 54%, and allogeneic transplants were reduced by 10 percentage points, 11, with the use of BV consolidation. In the absence of overall survival benefit, this data appear to be important and promising and justify the use of BV consolidation in this setting. In a small phase 2 trial, pembrolizumab was also given as consolidation after autologous transplant for 8 infusions, and the PFS at 18 months exceeded 80%, which was the primary endpoint, and this data appear very promising, but this strategy has not been approved yet. I would say that all these novel agents are very fascinating, but we should not forget the traditional approaches. So we recently published 2 cases of primary progressive Hodgkin lymphoma who were refractory to second-line salvage, achieved to be forwarded to autologous transplant with BRESAP, remained with residual disease after transplant, and then received BV consolidation. But because of the persistently localized disease, we also gave concomitant radiotherapy. And we show here that radiotherapy can be simultaneously given with BV consolidation and may be a life-saving approach in highly selected patients. So we can combine novelty with tradition, and we should never forget radiotherapy. However, the main question is what to do when autologous transplant fails. And this is the case in 50% of transplanted cases, and those who cannot be forwarded to transplant because of chemorefractoriness mainly. And here are the data published by Panagiotis Kalogiannidis. I had fixed this, but it's again not visible. Such patients have a median survival of no more than 2.5 years. And now they have available approaches including BV, PD-1 inhibitors. There are questions regarding allogeneic stem cell transplantation or a second autologous. Certainly, conventional chemotherapy with much less prospects, radiotherapy in highly selected patients, and why not, in a very small minority of patients, complete surgical excision. Among 400 patients with relapsed refractory Hodgkin lymphoma, we had 4 patients that had persistently relapsed refractory disease. 3 of them had received 5 to 6 prior therapies and were refractory, had received ASCT, autologous transplant, radiotherapy, investigational treatments, and had disease localized to the lungs or the mediastinum or the inguinal area, and were cured virtually with remissions lasting more than 5 years with curative radical surgery. This is not a recommendation, but is just a reminder that very few patients may be spared novel agents and be cured with surgery alone. I know that this is provocative, but it's the reality. So in the setting of post-ASCT failure, post-autologous failure, brentuximab vedotin appears to be very efficient with 74% response rates and 1/3 CRs for 34% in a very unfavorable patient population. And you can see here that there is some kind of plateau. And finally, 9 out of 102 patients who received brentuximab vedotin in this setting might have been cured, achieving only with BV, without further consolidation, durable remissions lasting more than 5 years. And this is achieved only with patients who achieve complete remission. I'm somewhat concerned if you can hear me. Is it okay? So I'm continuing. Following brentuximab vedotin failure in relapsed refractory Hodgkin lymphoma, the situation becomes even worse, and the response rates are 33%, with only 15% CRs with conventional chemotherapy. And only patients who are consolidated with some kind of transplant actually can be cured after failure of brentuximab vedotin. And here we have a great success with the introduction of PD-1 inhibitors in the treatment of classical Hodgkin lymphoma. PD-1 inhibitors in use are nivolumab and pembrolizumab, and also some other agents in China, and can salvage effectively patients who are near dead, as this lady, who achieved a complete remission with pembrolizumab at 3 months, and she had a very extensive disease. She got under oxygen therapy, extensive pulmonary involvement, and had never responded to any treatment. The clinical trials that produced our knowledge regarding nivolumab and pembrolizumab were Checkmate 205 and Keynote 87. There are 2 publications for each of 2 trials and 2 abstracts with the long-term follow-up data. And here I have summarized the response rates in different clinical scenarios. It appears that almost 70% of the patients actually respond, and 20 to 30% of the patients achieved complete remission with PD-1 inhibitors, but these are patients with performance status 0 to 1. In Checkmate 205 and in Keynote 87, you can see here that 50% of the patients who achieved complete remission maintain their complete remission at 3 years. And this is consistent along the 2 trials, while patients with partial remission have much worse outcomes. But the overall survival is much better than expected with conventional therapy. And you can see that at 3.5 years, more than 85% of the patients are alive, while the expected outcome should be a median survival of no more than 2 years. And patients who achieve CR, PR, or even stable disease with inhibitors have excellent overall survival rates, and only those with progressive disease actually have the poor outcome of relapsed refractory patients with median survival of 2 or 3 years. A novel point of view in the treatment of Hodgkin lymphoma is the observation that PD-1 inhibitors can be successfully continued even if patients experience disease progression during treatment with PD-1 inhibitors. And in the Checkmate 205 trial, patients with progressive disease received the treatment beyond progression or not, according to physician's judgment. And you can see here that patients who had progressive disease but continued treatment might experience even more disease reduction. And at the end, patients who were treated beyond progression, who were 2/3 of the patients who had progressive disease, had more or less the same outcome, the same overall survival, slightly worse, but more or less the same with those who did not progress. And only the minority of patients who progressed and changed treatment had clearly impaired overall survival. And furthermore, from the Keynote 87, we learned that patients who discontinue pembrolizumab after 2 years and then relapse or progress may be retreated with pembrolizumab with the same good response rates, overall 70% and almost 30% complete remissions. And this treatment beyond progression and the ability of successful retreatment has changed the fate of patients who fail autologous transplant and production of vedotin and increased overall survival at 1.5 or 2 years from 60% to 90%. It appears that this survival benefit persists up to 3-4 years and probably thereafter. However, there is a question whether PD-1 inhibitors are better than brentuximab vedotin for patients who fail autologous transplant or are ineligible for autologous transplant. This question was addressed by the Keynote 204 study, in which patients were randomized between pembrolizumab in the standard dose versus brentuximab vedotin for up to 2 years, 35 cycles, which is very unusual for brentuximab vedotin. Most patients in this trial had not undergone autologous transplant due to refractory disease, or some, 17%, due to age restrictions. And finally, after study drug, BV or pembrolizumab, 30% were transplanted, most with allogeneic and some with autologous transplantation. And there was a clear benefit in terms of disease control for pembrolizumab versus brentuximab vedotin, but we have no survival data, overall survival data yet. So it is clear for most subgroups that pembrolizumab is better in disease control than brentuximab vedotin, but we have to define the optimal sequence. If we should use brentuximab vedotin and early after the inability to achieve a complete response to pembrolizumab, or it would be wiser to use pembrolizumab straightforward prior to BV. The most unfortunate situation in patients with relapsed refractory Hodgkin lymphoma is the setting of failure after PD-1 inhibitors. And as I already said, failure, progressive disease under PD-1 inhibitors is not synonymous to treatment failure, but most patients can continue treatment with PD-1 inhibitors, enjoying very good quality of life and an equilibrium of the disease. But some patients have pressing symptoms which require the switch from PD-1 inhibitor to another treatment. In the reality, these patients may receive further chemotherapy, and there are some data, not very strong, but there are some data showing that after prior exposure to PD-1 inhibitors, subsequent chemotherapy may be more efficacious than previously was. And also, there is a major question regarding the timing of allogeneic stem cell transplant after response or after failure to PD-1 inhibitors. I have here summarized the experience on 75 patients after nivolumab or pembrolizumab. And theoretically, immune activation with PD-1 inhibitors might increase the risk and severity of GVHD, but might also improve disease control. It appears from the few data available that the total rates of GVHD, acute and chronic, remain unchanged, but grade 4 GVHD may be somewhat more common. There are a few cases of hyperacute and potentially lethal GVHD, and this is the reason for FDA label warning for ASCT after PD-1 inhibitors. Also, these patients may experience an atypical non-infectious febrile syndrome responsive to steroids, but non-relapse mortality, despite these problems, is not obviously worse than expected. So allogeneic transplant is not contraindicated after PD-1 inhibitors in classical Hodgkin lymphoma. And I will not insist in retrospective study showing that allogeneic transplant is feasible and probably efficacious after PD-1 inhibitors. We can discuss it in the discussion part. Also, except of sensitization to chemotherapy and allogeneic transplantation, there is another fascinating way to treat patients who fail PD-1 inhibitors. It appears that hypomethylating agents may synergize with PD-1 inhibitors, and these anecdotal effects, anecdotal reports, limited data, suggesting that patients who had been pretreated with azacitidine within clinical trials had better responses to PD-1 inhibition. But recently, a phase 2 trial was published comparing camrelizumab, a PD-1 inhibitor in China, plus decitabine or camrelizumab alone in 61 patients who were PD-1 naive and were randomized to the combination versus camrelizumab alone, and 25 patients who had been refractory or relapsed after PD-1 inhibitors and were treated with the combination. This is the dose, and because in China, autologous transplant and BV may not be available, patients having been exposed to these strategies were rather few. But you can see here that the combination of decitabine and camrelizumab provided in PD-1 naive patients very, very high response rates and an exceptionally high CR rate, and in patients who had been exposed and relapsed or progressed under PD-1 inhibitors, there was still a 50% chance of response and almost 30% complete response. And here you can see the duration of response in these patient subgroups. This appears to be a very promising strategy. And there are also other agents, experimental, or as the AFM13 monoclonal antibody and CAR T cells and probably others, which can stand alone or in combination with PD-1 inhibitors, but are not currently available. So, in order to conclude, I would say that immunotherapy represents a great progress in the management of relapsed refractory classical Hodgkin lymphoma, provides benefits in disease control, and obviously, I would say, prolongation of overall survival during the last 5 years in patients who have failed autologous transplant and who had until that time no other treatment options. A considerable percentage of patients can achieve long-term remissions which might correspond to cure, and we have great expectations with incorporation of immunotherapy into the first and the second line treatment of lymphoma. PD-1 inhibitors now are in the fourth line of treatment according to the official indications. Probably they can be moved earlier. They are very effective in clearly desperate clinical scenario, but we have issues regarding the optimal treatment duration, which is not well defined yet. And we have the novel observation that if we continue treatment of non-responders or patients with progressive disease with PD-1 inhibitors, maybe we can have a further treatment option because these drugs function very differently than conventional chemotherapy. And all this success has made the role of an allogeneic transplant controversial. And I will end with some suggestions by Herbeau in Blood 2018 regarding the role of allogeneic transplant. The authors do not recommend using the depth of remission as the sole criterion for determining the suitability of patients for autologous stem cell transplantation after PD-1 inhibitors. Given the favorable safety profile of PD-1 inhibitors and the toxicity of allogeneic transplant, the authors favor keeping responders on therapy instead of stopping therapy to proceed to allogeneic transplant. It is frequently possible, as I already said, to induce remission after failure of PD-1 blockade, but patients who experience failure on PD-1 inhibitors are strongly recommended to be referred to transplant center, at least to discuss considerations around allogeneic transplant and prepare for a potential transplant. However, all these decisions are highly individualized because the risk of allogeneic transplant is really high. Thank you very much.
Thank you, Theodoros, for this very informative and comprehensive review of relapsed refractory Hodgkin's lymphoma. I encourage all the participants to please type their questions in so we can have a very productive discussion. So I would like to start the discussion. So it's very interesting, Theodoros, that in the beginning you presented a retrospective study by the German Hodgkin's lymphoma study group in which patients with localized relapse of Hodgkin's lymphoma were offered salvage single radiotherapy alone. And the failure-free survival, if I'm not correct, was around 22% at 6 years, which I would guess is inferior to what we would expect after salvage chemotherapy and autologous stem cell transplantation. But still, definitely some patients will benefit from this treatment, which is radiotherapy alone. So would you like to express your opinion on this issue, and which patients you think we would pursue this approach of just radiation after relapse?
Yes, this is a very important approach, which is usually overlooked due to the availability of transplant strategies and novel agents. The success rate is 22%, but this was prior to the PET era. Probably there were, I'm sure that in this series of 100 patients, there were many patients who had not really localized relapse because they had not they had not undergone PET. So if you select these patients by PET, and it is clear that they have radiotherapy amenable disease, and it's clear that this is outside previous radiation fields, and especially if they are asymptomatic and have late relapses, they are not primary refractory, salvage radiotherapy may be exceptionally effective. And we try to use salvage radiotherapy in suitable patients prior to any transplant attempt.
Thank you. We have one question by Dr. Alaska. So the question is, excellent overview, thank you. We have seen persistent PET positivity while patients on nivolumab as a single agent in a refractory case to multiple lines, while clinically stable. So what is your experience?
I wonder if we can return to the presentation, because I have skipped some slides describing very well this very important phenomenon. Can we go back to the presentation? Okay. Just a moment. This is the scenario for treatment beyond progression, but I have a case that is unique. This here, 62-year-old female, classical Hodgkin lymphoma nodular sclerosing stage 3B on 2014. ABVD times 7, progressive disease during treatment. Despite the negative interim PET, she received IGEV and then ESAP. She had progressive disease to each of these regimens with B symptoms, every time B symptoms, pruritus, and worsening lymphadenopathy. She's not eligible for autologous. She's totally chemorefractory. She received BV. Again, she had progressive disease with B symptoms, pruritus, and worsening anatomic findings, and elevated sedimentation rate and CRP. She received 2 cycles of BCOP escalated, again the same result, and she had extensive and symptomatic disease. This patient, in my view, would be dead within 3 months, 4 months, because the disease was very pressing clinically. It was symptomatic. She was initiated with Nivo on March 2016. And this is the physical examination on Nivo initiation, and had a highly elevated CRP and sedimentation rate, and was symptomatic. On day 15, she was completely afebrile and asymptomatic. At 3 infusions, 1.5 months, physical examination is much better. And at 6 infusions, at 3 months, PET is this one. It's not bad, but it's highly positive. SUV is high, and at 6 months, PET findings are worse. And SUV is 23, and there is clear progressive disease. You can see here the nodes. We continue with nivolumab because the patient is clinically stable. She's afebrile and has no elevated inflammation markers. And at 1 year, there is further progression in para-aortic nodes, and also more nodes in the left axilla. But we continue. At 2 years, she develops lymphadenopathy, 4 centimeter, clinically palpable in the left axilla, and we perform lymph node biopsy, and it's nodular sclerosing Hodgkin lymphoma. But we continue because the patient is in a good shape. She's completely asymptomatic. At 3.5 years following nivo, she has para-aortic progression, but we continue. And now we are almost 5 years on nivo with walks and warning disease. We have stopped to perform PET because PET is highly positive, strongly positive, but the patient is in good shape. And she's almost 5 years with full-blown disease, but no symptoms and excellent quality of life and no meaningful side effects. This is an extreme paradigm of treatment beyond progression, and probably we can maintain patients under PD-1 inhibition for very prolonged time periods, even if conventionally defined progressive disease occurs. This is a very different point of view of the treatment of classical Hodgkin lymphoma than was with conventional chemotherapy. I think that this case is very, very informative. And this is the response to Professor Raskar.
So, Theodoros, I will agree with you, and we have similar experience in our center. I remember recently we had a patient, a 35-year-old patient who had multiple lines of therapy, 4 or 5 lines of therapy, and he was tired of receiving chemotherapy. He said, "I don't want any more chemotherapy. Please give me something else." He was a very, very difficult personality, actually. So we gave him a PD-1 inhibitor. I think we gave him nivolumab, and he had a reasonably good response with a PET scan. And he was on nivolumab for a year. He was doing very well. And I lost him to follow-up. He was actually seen by another colleague. But they about 16 months after initiating nivolumab, they brought him to the tumor board meeting with a new PET scan. So the PET scan, just to update the period, it was like a Christmas tree. So I said, "Wow, he's got progressive disease." I said, "I have to see this patient next time in the clinic." So he came to the clinic, and as he walked in, I said to him, "How are you?" And he said, "I've never felt better in my life." So I agree with you that patients might have progression of disease, but oddly, they have extremely very good quality of life. And I agree with you that maybe these patients should not be scanned at all with PET scans because they confuse you. And this patient, he actually discouraged me from stopping the treatment. He said, don't, I feel very well. So I concur with what you said. And I think we have the similar experience with our patients. So we have another question by Dr. Alaska. Oh, sorry, Ahmed Al-Said, sorry. So the question is, do you think improving conditioning regimen would be another strategy to improve transplant outcome?
I think that improving the toxicity of the conditioning would be the strategy to improve the outcome, because the main problem with allogeneic transplant is the toxicity. The main question is whether we perform allogeneic transplants in these patients, especially because PD-1 inhibitors are easy to handle, and because even in the absence of response, the good clinical outcome is maintained. So there are some data showing better outcomes with prophylaxis GVHD prophylaxis with post-transplant cyclophosphamide. I think that the goal should be the reduction of the toxicity of allogeneic transplant in this population.
Sorry, but maybe a part of this question might be the improvement of the conditioning regimen. You can assume might be incorporating the novel agents. For example, what's your opinion on the combination of BV plus an immune checkpoint inhibitor as salvage therapy?
Yes, there are data on this as second-line salvage, and it appears that most patients can be forwarded effectively to autologous transplant with BV-nivo, although CR are in the order of metabolic CR in the order of 50%, but overall response rate is very high. So chemo-free approaches are clearly feasible and effective as salvage regimens. And I think that the goal should be to spare multiple therapies and allogeneic transplant with by improving first and second line therapies and stop the disease at the level of autologous transplant. So novel agents might have the best their best place probably in the second line.
So do you think this combination should be compared with traditional salvage regimens in a phase 3 randomized trial? Do you think it's going to happen, or?
I would be more in favor of BRESAP or BV-DHAP or BV-BENDA and not BV-nivo, because this exhausts the options after ASCT failure. So I would like to see a randomized trial of conventional salvage versus BV-based salvage. And in fact, there is a current randomized trial by the Spanish group, and we are trying to be included also, comparing BRESAP with ESAP. I think that brentuximab vedotin may have a very good place at the second line and will maximize the effectiveness of autologous transplant results.
But there is a trend to try and bring these new agents up front. For example, as you're aware, the SWOG group in the US is now conducting a randomized phase 3 trial in the upfront setting, comparing BV-AVD with DIVO-AVD.
This is very, very important, but in most patients it's not needed because they will be cured with ABVD. So we should see which patients will require novel agent plus AVD. It is not for all. For early stages, I think that it is too much.
Okay, there's an interesting
advanced stages.
There's an interesting question. So the question is, what is your thought about refractoriness in the form of isolated mass? Would you first try either radiotherapy or, as you have suggested, surgical resection plus minus BV before considering auto stem cell transplantation?
I am very enthusiastic about local therapies in such cases, but I would not overlook autologous transplant. We should not forget radiotherapy, because now we name patients as refractory and try more chemotherapy, more BV, more PD-1 inhibitors without radiotherapy. So radiotherapy is a crucial approach for Hodgkin lymphoma, especially if it is localized. But I would not give salvage radiotherapy in patients with refractory disease. I would give with progressive disease. I would give salvage radiotherapy in partial responders or in patients who have isolated relapses, but not in primary progressive patients who have progressive disease very close to the end of primary therapy. Surgical resection is very provocative, but should be reserved for the very few patients that have persistently localized relapsing or refractory disease. All these patients that I described in my talk had had failed 5 to 6 prior regimens, and they were prior to BV and PD-1 inhibitor availability. So if you have a patient, a rare patient, that always progresses at the same site, even after radiotherapy, surgical resection can be considered. This is not a usual strategy, but may be efficient in very, very rare but existent patients.
So the question is, so if you have a patient with relapsed refractory Hodgkin's who has bulky disease and who achieves metabolic complete remission following auto stem cell transplantation, in which patients, if you see any role of consolidation radiotherapy to the residual sites of bulky disease?
I would consider radiotherapy if PET was positive prior to auto transplant.
Right. So if the patient is,
this is not proven. It's my impression.
Yes, no, I agree with you. That's why I asked you. I wanted your opinion. So if a patient is PET negative before the transplant, and he goes ahead, and at the end he has a residual mass, which either way would be PET negative again after the auto, you would not irradiate it, right?
Patients who are PET negative prior and post auto transplant have more than 80% of cure, chance of cure. I have no data regarding subgroup analysis in terms of bulk, because these patients are not very common, but I would not change the strategy just because of conventionally defined bulky disease. Except if the residual mass was 7-8 centimeters, probably. In that case, I would decide individual manner.
Right. Okay, so can we go back to the AETHERA trial? So we've seen the data of maintenance brentuximab. After 5 years of follow-up, there's still a significant 10% progression-free survival difference, okay, in favor of BV maintenance. So what do you do in your practice, in your department? With the exception of those who are, let's say, PET negative, which is debatable, would you be giving to all these patients maintenance brentuximab?
We give certainly brentuximab maintenance to those who were forwarded to transplant with BV-based regimens. If a patient is PET positive, strongly positive after IGEV, and then you give BRESAP or BV bridging, and it's forwarded to autologous, then we certainly give BV consolidation. We also give BV consolidation in patients at high risk because there is a clear indication. But in my view, the benefit is not so much. There is benefit in disease control, but no benefit in overall survival. I think that one could wait and see the 3-month PET after transplant, because patients who are PET negative or PET positive prior to transplant and are PET negative at 3 months post-transplant, irrespective of the PET result prior to transplant, they have excellent outcomes. So I would, in my opinion, one could wait for 3 months, and if he has progressive disease, then he would give BV salvage therapy. But if PET is still negative at 3 months, I would not consider BV consolidation. Based on the indication, all patients who are at high risk should receive BV consolidation. But in my opinion, if the start of BV consolidation is delayed from 1.5 months to 3 months, if PET is negative at that point, probably BV consolidation could be skipped. This is a personal view.
Okay, so we'll go to possibly the last question now. It's from Dr. Rawan Alomari. So it says, good evening, great talk. If a patient was refractory upfront to AAVD and he was primary refractory, would you consider BV maintenance post-transplant, or may there be other option?
Speaking based on the common sense, not. I would not consider BV consolidation because he has proven resistance to BV. There's
So
no direct
how
answer.
how would you approach this patient?
How?
How would you approach this patient? How would you treat him? Failure of AAVD, primary refractory.
Yes. Conventional salvage therapy, primary refractory to AAVD. Conventional salvage therapy, and to try to proceed to autologous transplant. And probably now we will have approval for pembrolizumab in this setting. The keynote 204 will be published in Lancet Oncology very soon, and I think that FDA will approve this indication even after just one line of therapy. Pembrolizumab appears to be superior to BV, and if in this specific setting that BV has been exhausted in the first line, probably pembrolizumab may be a good option. But in any case, I would try to get chemosensitivity and autologous transplant at least with one regimen prior to any PD-1 inhibitor treatment.
Okay, thank you. So the time's over, so we have to conclude this webinar. I would like to thank Dr. Vassilakopoulos for his valuable input. I'd like to thank the audience for their attendance and their questions to our speaker. Special thanks to Takeda for their support, and personally to Dr. Al-Askar, President of the SSBMT, for his dedicated commitment in providing these educational activities in the form of webcasts. So I would like to wish everybody a happy new year. Next year's program will continue. I don't know if Dr. Al-Askar would like to add a few words, if he can hear us.
Great talk, and
anyway, I don't have, oh, here he is. Okay.
do you hear me?
So Dr. Al-Askar.
Yes. Well, thank you again, Dr. Theodoros, for such a great talk, and John for moderating such a session. I'm looking forward to meet our audience again in the next upcoming webinar. Thank you all, and have a nice evening.
Thank you. Goodbye. Bye-bye, Theodoros.
Bye-bye, Yanis. We'll be in touch.